Welcome. I'm pleased to introduce Dr. Scott Perry. He's a neurologist at Cook Children's, and his Twitter handle is the Notorious EEG, where you can follow him for dad jokes and lots of educational information about various forms of epilepsy all around the country. He's on the scientific board for the Brain Recovery Project and was at the PCORI conference yesterday and has been just a really great help in figuring out how do we navigate this research space. He's also the neurosurgery director of the PERC. Is that right?
The director of the surgery, surgery portion of
the
PERC. Director
of the epilepsy surgery portion of the Pediatric Epilepsy Research Consortium, which is the. Anyway, it's similar to collecting outcomes from many different institutions to get a good handle on what happens after the surgeries. So I think he's going to talk about what Dr. Kolb said not to do, which is to give marijuana to kids. So I'll let you talk about that one now. All right, thanks.
It's not exactly what he said. All right, so first of all, thank you for inviting me to be here. It's been great to work with this group. I'm actually just a little bit surprised that there's not more people in the room, but I think that is because everyone has surely been to a talk about cannabis by now in epilepsy, because it has to be. No, great, so someone has not had it. You and I will tell you what you want to know, I hope.
And I might have to find you, because I've got to be out there when my
Fair enough, I will be around, So as an informal beginning introduction, and no fear of prosecution here, how many people have used CBD for themselves or their child for something? Okay. How many people have certainly, obviously, thought about it? And how many of you have been told by your neighbor or your aunt or your uncle or your grandparent or your best friend that you absolutely need to do this for your child, even though they don't have a child with epilepsy and they probably don't have any clue? Okay. All right. Fair enough. I mean, it's everywhere, right? It's not. There's not a day that goes by in my life that I am not asked about CBD. I'll begin with some disclaimers. I do own stock in a couple companies that are investigating treatments in CBD. One of them is bankrupt, so for what that's worth, lost that money. I have served as a principal investigator for Greenwich, which developed Epidiolex for Lennox-Gastaut, Dravet, and Tuberous Sclerosis Complex, and I have received some honoraria from a dispensary in the state of Texas in helping them navigate the Texas Compassionate Use Law, which I helped pass a few years ago. And as I said, not a day goes by that people don't ask me about CBD, and I didn't mean to get into CBD as a treatment for epilepsy. I didn't mean to learn a lot about it, but I do genetic epilepsy, and so I take care of a lot of children with Dravet syndrome, which was really where the CBD craze kind of started. And as a result, all these patients that I take care of, wanted to use it, and I had choices. I could either not know anything about it and let them go do whatever and not understand what was going on, or try to learn a little something about it. And so that's kind of how it started. So what I want you to kind of get by the time you go home, if you didn't already know this, is that there is in fact evidence that cannabidiol, or what people call CBD, is useful as a treatment for refractory epilepsy. There is potential that the plant contains other things that may be useful for treatment of epilepsy and other conditions. Like all medicines that are available to treat disease, there is no cannabis oil that is the magic potion for all children. Some children will respond very well to it, but some will not respond at all. There are differences between what we consider pharma-grade, or the FDA-approved version Epidiolex, and what you might get at a dispensary, and there are differences in what you might get at your local gas station or at your hair salon, as I saw it in Texas the other day when I was getting my hair cut. No medication, whether it be natural or synthetic, is without adverse effects. Everything comes with an adverse effect, some better than others. And the quality of the research for CBD as a use for treatment for things beyond epilepsy is still lacking. So it doesn't mean it doesn't work for other things. It just means when you go to your doctor and you say, hey, can I use it for this? It's going to be very difficult for them to give you a good, straightforward answer, because as you're seeing with the lack of research for many of the questions you have here for these large disconnective surgeries, there's a lack of research for CBD as well. So what I'll do is I'll briefly review the history of cannabis in medicine, particularly as it pertains to epilepsy. We'll discuss, the way I'm going to do it is I'm going to start with evidence from the beginning, or near the beginning of cannabis becoming of interest again in medicine, and walk you through how the research developed. And the purpose for that is that I want you to, again, understand when you go to your doctor and you ask about some other condition, they say, well, there's not good evidence for that. And you go, yes, there is. I saw it on the internet. There are these papers. We'll go through why those papers aren't the best and how the research builds up to what we consider gold standard research, which is placebo-controlled double-blinded trials. And so that is the point in which I'll get to the phase 3 trials, which were the FDA drug trials of Epidiolex. We'll go over that data. We'll talk about the known drug interactions and adverse effects. I'll briefly go over the potential for use of CBD in some other conditions. And finally, just speak briefly about some of the differences in what some people like to call artisanal CBD products, or again, basically any CBD product you don't get from a prescription from the pharmacy. That's called Epidiolex. So cannabis. Cannabis is not new in medicine. This is not a new idea. It has been used for centuries. It was used for rope, clothing, paper, oils, feed, and yes, for medicine many, many years ago. The first documented uses were back in 2700 BC by the Chinese, and just like today, they used it for all kinds of stuff. Gout, malaria, rheumatism, a variety of other things. Its first use for epilepsy is in some Middle Eastern texts around 1800 BC, where it was used in what they described as nocturnal convulsions. The more kind of modern discussion came from a man named William O'Shaughnessy, who talked about bringing something called a tincture of hemp back from India. And he wrote about using it in an infant who had seizures. And as I read his description of how he used it, again, it seems very similar to some of the things we see on the internet these days, right? So he took a drop equal to 1/20th a part of grain in weight placed on the child's tongue. Now, if you've bought any of these oils on the internet and asked them what is the dose, they say about a grain of rice or something. Like, how is that a way to measure? I don't know, but that's the way they measure things. So just like that back then, they used some kind of difficult measurements. And as you see, it was a little bit of trial and error. As he talks about, he used it, didn't really see any change. He used a little bit more. He got up to like 40 drops or something like that, and finally thought he originally saw some improvement, but then didn't see improvement. So there's kind of ups and downs to what he was seeing in the effect of this medicine as he was using it. But cannabis was used in medicine, in Western medicine for some time, mostly for pain control until aspirin was invented. And then it kind of started to disappear, but it continued to be used for epilepsy to some degree. But in the 19th and 20th centuries, the attention of medicine turned away from using whole plant treatments and started to look more on individual chemical entities, whether they came from plants or whether they were synthetically developed. And then in 1937, something called the Marijuana Tax Act was passed. And this act said that in order to use marijuana, it had to be used for medicine, and there would be a tax applied to it. Now, this created a lot of problems because by 1937, it wasn't being used just for medicine. It had psychoactive effects. It was being used for its psychoactive effects. And so thus, those people who were using it prior to 1937 relatively freely now had to use it more on an illegal basis because they didn't want to pay a tax on it, nor did they, it's obviously illegal because it could only be used for medicine. So then trials started to become a little less frequent again, as I said, but then it also became a drug that it became more of a drug of abuse to some degree. And then in 1969, the Marijuana Tax Act was struck down as being illegal because it violated your right to avoid self-incrimination. And so that is when the DEA created the DEA schedule. And the DEA schedule lists, as you may know, medicines and the effect they have and whether or not they're useful. And Schedule 1 drugs are drugs which are considered to have no medicinal effect. And so that's where marijuana ended up, and that's largely where it began to disappear. So while there were some early studies in the 1960s and 70s about epilepsy, they were generally studies of people who were smoking marijuana and happened to have epilepsy. As a result, these studies weren't very good because you had really no way to standardize what they were smoking. Each person smoking a little something different, smoking a different amount. They all had different kinds of epilepsy, and some of them reported they got better, some of them reported they got worse, and so you couldn't really draw any conclusions. There were a few studies in the 70s and 80s, and these were prospective trials. Prospective trials are better than retrospective trials. So prospective trials are trials where we start now and we gather the information we want to, as opposed to a retrospective trial where we say, this is what we want to know, let's go back in the chart and try to figure it out. Retrospective trials are tough because if you don't have the information there, you don't have the information there. So these prospective trials were good, but they were very small. So they had between 4 and 12 patients. Only one of them had a placebo group. Placebos are important because they help eliminate bias. Only one of these was double-blinded. Double-blinding is also important because it eliminates bias. So double-blinding means when we do a trial, I don't know if you're on the active medicine, and you don't know if you're on the active medicine. You don't know if you're on placebo, and you don't know if you're on the real drug. And we don't know anything until the study's over, and frankly, when the study's over, we don't always know either. It's analyzed by the statisticians, and there are your results. And that's what helps you learn if it was useful or not. So, as I said, interest really died out until Charlotte. And many of you, I'm sure, know Charlotte's story. This is Charlotte Figge. Charlotte's a young girl who lived in Colorado. She has Dravet syndrome. She had hundreds and hundreds of seizures a day. Her mom tried lots and lots of things, and nothing really worked. So she turned to the Stanley brothers to help develop a treatment using cannabis, and they created a CBD oil now known as Charlotte's Web. And Charlotte certainly improved on Charlotte's Web. Charlotte did not become seizure-free on Charlotte's Web, but she had a significant reduction in her seizures. Her quality of life has improved significantly. Charlotte wasn't the only one who got things going. A man named Sanjay Gupta also helped us out. He did several shows on CNN, which stoked a great deal of interest in the potential for CBD and really got the craze going, I guess. So just going to go over some basic science and terminology, and it really doesn't matter what I tell you in this section because it's going to be written so many different ways on the internet, and people are going to use these words so many different ways, it's still going to be confusing when it's all said and done. But cannabis, there's basically 3 types of cannabis that people talk about: sativa, indica, and ruralis. They are some considered somewhat different species of cannabis. Other people consider them to all be the exact same plant. They just happen to have different ratios of their cannabinoids. Hemp is a word that has traditionally meant a plant that has less than 0.3% THC. THC is the psychoactive component of the plant, the part of the plant that causes the high. So hemp also refers to the use of the stalk of the plant and the seeds of the plant to use for things like paper and rope and clothing. Some people buy things called hemp oils, and if using the term correctly, then a hemp oil is basically a hemp plant that's been ground up and made into an oil, and the amount of CBD in it honestly is not going to be all that much because there's not a lot of CBD in the hemp plant. Most CBD and THC resides in the flower part of the plant, and hemp plants don't make flowers, or they don't make a lot of flowers. So some people may buy hemp oil and come and see me and say, yes, I'm using CBD. In reality, maybe they're not really getting that much CBD at all. On the other hand, many people who make CBD oils call them hemp oils, and so maybe they are getting CBD. Very difficult to know. Cannabis can refer to the leaves and the flowers of the plant. We use the term when we're talking about using it for therapy. Usually when we use the word marijuana, we're defining a drug of abuse when we use that. Some people like to use the word medical marijuana, probably not the best choice of words. So the plant itself has 500 chemical components to it or more, and over 100 of those are phytocannabinoids. So phytocannabinoids are cannabinoids from a plant. That's what that means. And cannabidiol is only one of the over 100 phytocannabinoids in the plant. So when you think of it as a drug to treat epilepsy, think of cannabidiol being trileptal. And in the plant also contains phenytoin, and it also contains Keppra, and it also has Depakote. All right, so there's lots of things in the plant, and you're trying to extract individual components of it. So as I said, there's 2 main components, delta-9 THC, which is the psychoactive component, and the non-psychoactive CBD. Again, a variety of other components. Many of these are being isolated and looked at as potential treatments for epilepsy, but they are far down the line right now. And it is not going to be a quick process. If you have 100 different things in there and each one needs to go through purification and study, it may take quite some time. And you'll have people who argue that you need CBD plus a bunch of these other things, and how you know which of these other things you need to get the most, perfect seizure efficacy drug is a very long and difficult process. So the endocannabinoid system is the system within our body that cannabinoids interact with. So this was discovered in the 1960s. There's two receptors. The CB1 receptor is the one that is most highly expressed in the nervous system. You find it in many of the neurons of the brain, especially around the hippocampus, the amygdala, the cingulate, as well as the cerebral cortex. All of these are areas where seizures can be generated, as well as the basal ganglia, midbrain, and medulla. The CB1 receptor, and I'll tell this in a few slides from now, when I say it now, is CBD does not react or does not interact with the CB1 receptor. THC does. It's one of the reasons THC gives you some of that psychoactive feelings, because the CB1 receptor is in areas of the brain that are responsible for things like emotion, the hippocampus and the amygdala in that system. The CB2 receptors are in areas of more peripheral immune systems, such as the spleen and the bone marrow and macrophages, cells that deal with infection. And so that's one of the reasons you may see a lot that people are talking about it as a use for inflammatory processes, and that there's potentially some benefit. So we have our own endogenous cannabinoids, or endocannabinoids, that bind to these receptors. And when they bind to these receptors in our body, they release neurotransmitters. GABA is one of the neurotransmitters. GABA is the neurotransmitter that is inhibitory. So in the world of treating epilepsy, you got two approaches, all right? You got too much electricity. So you can either decrease the amount of neurotransmitters that induce electricity, that would be things like glutamate, or you can increase the amount of neurotransmitters that inhibit electricity, that would be GABA. And so one of the benefits potentially of CBD is that it appears to do several things. And may act in several different ways. So we talked about THC already briefly. As far as data for it as a treatment of epilepsy, there are some studies that show that it might be beneficial for epilepsy, but there are not enough of them that have the same results. Some are good, some are bad. There's potentially a threshold to it, so maybe very low amounts might be useful, and then after that it appears that it actually causes seizures, makes things worse. Despite that, animal studies show that early tolerance is built to THC. So if you were to use it as a seizure drug, it appears that you develop tolerance to it quite quickly. So for a chronic disease, it's probably not a good choice for therapy. Beyond that, there is extensive data on its potential to result in problems with cognition, behavioral impacts, potentially further to addiction. And so given all of that, out of the 100 things in the plant, THC can't be the best thing we can look at for epilepsy. We should focus on some of the others. So CBD, as I said, is the one that's the most popularized and has been studied the most. It acts in a variety of different signaling systems in the central nervous system, most recently in cells from Dravet patients. It was shown to do just what I said, is that it actually helped inhibitory neurons do a better job, and it actually decreased the amount of work excitatory neurons did. So it worked in both pathways to potentially be one reason that it may improve seizures in children with Dravet syndrome. CBD can be administered various ways. You could administer it by smoking it, but I don't think any drug probably should be smoked. That's probably not a good way to treat anything. Vaporization is an option. Oil-based oral is an option, and given sublingually or under the tongue. It likes fat, so that's the best way for it to be given. That's why it's suspended in oil. It is absorbed better if it's given with fatty meals. It is metabolized in the liver by multiple enzymes in the liver that are also responsible for metabolizing other drugs, especially seizure drugs. So that's why it's important to understand the interactions as a result. And it has a very long half-life. So the half-life is the amount of time it takes for the body to metabolize it and get it out of your system. A long half-life is good for seizure drugs because, number one, it really helps create a fairly steady level. The other thing is it helps to develop a medicine that doesn't have to be given multiple times a day. Like Neurontin, gabapentin has a very short half-life, and so it is given 3 to 4 times a day to keep this level steady, whereas CBD could be given less, currently recommended to be given twice a day. So, why is everybody so excited about it? Well, it's all over the internet. There's plenty of reports about how awesome it is and how it fixes everything. They've been able to wean off other medications, which is great. They've seen improvement in areas maybe beyond seizures, so cognition, behavior, energy level, and just as a natural desire, which makes perfectly good sense, to use natural things instead of having to use medicines that are developed in a lab. All makes good sense. Why is the medical community a little less excited? Well, number one, because we must be skeptical of everything. You know, I mean, when a person comes to me with their child and asks me what they should put in their child's body, I would like very good evidence to tell them what to do, knowing that one, may be able to help them, and two, not harm them, which is our first rule of thumb, is to do no harm. So we do require very sound science that proves both that efficacy and safety. And to prove that, as I said, we want it to be a double-blinded, placebo-controlled trial to give us the evidence we need. Outside of, Epidiolex and the trials in CBD, even before this, you would have had problems because the legality around CBD is incredibly confusing, state to state and nationally, right? So it is, Epidiolex is no longer Schedule 1, so CBD as Epidiolex is not a Schedule 1 drug, but all other things in marijuana still hang out in Schedule 1, right? And while our federal government has it sometimes said outright, we've got better things to do than prosecute people that use CBD, our current government reversed that decision and said they reserve the right at any time they want to prosecute people who violate the law. And as a doctor who worked a long time to get my license to get where I am, I'm not really interested in risking it. So I'll just, hang back. We created the law in Texas to try to create one more layer of protection to maybe allow us to help people out, but still the law in Texas does not override the federal law. So if the federal government decided they wanted to do something about it, they could. And as we'll talk about at the end, the reliability of CBD products other than Epidiolex is uncertain. It's not uncertain because I necessarily think everyone that's selling these is trying to fool you or cheat you out of it, but they are supplements. And so as supplements, they are not regulated. So there is no third-party oversight to look at them and tell you what the bottle says is what is actually in the bottle. And if you bought the CBD oils, many times you'll see the bottle doesn't really tell you what's in it in the first place. So now we're going to start going through the research from the beginning to where we are now. So we'll start with this first one. This was a Facebook survey of people who were using CBD products for epilepsy. And this is a good start. This was right at the beginning, and this was showing, so there are 19 respondents in this survey. Most of them had Dravet syndrome, some Lennox-Gastaut syndrome, and other epilepsies. And 68% reported more than a 50% reduction in their seizures. And that 50% number is important. So when the FDA approves a drug, they're looking for the percentage of people that have greater than 50% reduction because that's considered at least a useful reduction in seizures, right? So this was good, but the problem is that this Facebook group contained about 160 people, and yet only 19 responded. So did those 19 respond because they were the 19 that were doing really well? This Facebook group was dedicated to the use of CBD in medicine, so these are people who are already on board. So either you got 19 people who are doing well and the other didn't have anything to talk about, or maybe these were just the 19 that wanted to fill it out, hard to know. All of them were on slightly different compounds, so you can't make much decision from that, and they were on it for various amounts of time, from anywhere from 2 weeks to some over 1 year. So then this next study, it was done by Dr. Sankar, who was here yesterday, and his group, is a little bit better. Okay, it's a survey also, but now they are at least looking at the same kind of epilepsy. So they've brought together a group of people who have Lennox-Gastaut syndrome and infantile spasms and are using CBD products. And in this case, they had 117 people respond. Most of them, not quite most of them, a little over half of them responded with what they were using, and they were able to determine that most of them were at a 15-to-1 CBD to THC ratio, so they were high CBD products at an average of 4.3 milligrams per kilogram per day, and they had been treated for at least 6 months. And 85% of them reported improvement in seizures. I don't know what improvement is, though. I mean, is that 10%? Is that 50%? I don't know. But 14% of them said they were seizure-free. So I think that's something to take away from this one, that there are people who are using it who reported to be seizure-free. Phenytoin was associated with an unfavorable response, and now we know that's not surprising because those medications interact, and so it would have decreased potentially some of the efficacy. And the adverse effects were things like increased appetite and weight gain. So then the next studies come from Colorado, and I think these studies are very interesting. From the idea of bias. So these, in Colorado, you have a registry when you get CBD products. So they looked at their registry and they looked to see what kind of improvement were being reported. And 57% of the people in the study who were on CBD reported improvement, and a third of them reported at least 50% reduction in seizures. So that's very good. What's interesting is that the patients who moved to the state of Colorado to get CBD were statistically much more likely to report significant improvement in their seizures than the people who lived in the state to start with. That makes perfectly good sense to me. I've seen these families who left Texas. That's the reason we started the Texas Compassionate Use Act, because I didn't think these people should move away from their support just to get to CBD. And I can imagine if I had picked up my family and moved them there, I'd want it to work too. Adverse effects reported increased seizures, interestingly, and fatigue. There was a second study from this same group, also looked at the registry, and what they did is they looked at the amount of people who were still on it, I believe after about a year's worth of time, as a way to kind of get a feeling for efficacy. And what they found is that 71% of the people who had started were no longer on it a year later. And so that could be because it didn't work. It could be because they couldn't afford it. Right? You know, it can be quite expensive, not being covered by insurance. I imagine many of them just ultimately could not afford it. 24% of the people in the study did report a 50% reduction, and just like the previous study, if you relocated to Colorado, you were much more likely to still be on it and much more likely to report it was useful. In fact, even the people that moved from elsewhere to Colorado, even if they said the seizures were no better, still remained on it and felt it was useful. And again, it could have been useful for many other things beyond the seizures. So here's our problem, right? Everybody's getting really excited. Everybody was using it. It was getting way out of hand. It's still way out of hand, frankly, but it was getting out of hand. You had too many people using it. We just didn't have good data. But we did have Greenwich working on a purified CBD, which we now have FDA approved, called Epidiolex. So this is basically nearly pure cannabidiol. So you've taken a plant. They take plants that are clones of each other. That's actually important because every plant is exactly identical to the other plant. The cannabis plant can be vastly different depending on where it's grown and how it's treated. So all the plants are the same. They're grown under incredibly strict conditions. You take the plants, you grind them up, you take them through a very strict chemical process so that you extract cannabidiol out of it and basically have now purified cannabidiol and left the other stuff behind, very trace amounts of anything else. So it is currently indicated in the United States for the treatment of Lennox-Gastaut syndrome and Dravet syndrome. Recent studies have been completed in tuberous sclerosis syndrome, and I suspect it will be approved for that as well. So let's go through the studies one by one. So the first one was in Dravet syndrome. So this is 120 patients. They were all children, 2 to 18 years of age. To enter the study, you needed Dravet syndrome. You needed to have uncontrolled seizures defined as greater than 4 convulsive seizures in a 28-day period. And they were treated with 20 milligrams per kilogram of Epidiolex versus placebo. I'll just point out the dose because, again, any of you who have bought online CBD oils from places like Charlotte's Web or Haley's Hope, often the doses come in somewhere in the range of 2 to 4 milligrams per kilogram. And so this is a different dosing scheme too. And so they were given either the treatment or placebo and treated over a 14-week period. Parents had to count seizures every single day and turn them in with electronic diary. And our primary endpoint was looking to see what was the reduction in the convulsive seizures. And so people that were on CBD had an average of a little over 12 seizures a month, which was reduced to about 6. That was a 39% reduction in seizures versus the placebo group, which had a 13% reduction. Placebo groups always get better in studies. Why do they get better in studies? Because they're in a study. When you're in a study, you do everything you're supposed to do. You give all your medicines when you're supposed to give them, you don't miss doses, and your seizures always get better. That's one reason. And the other reason you get better is something called regression to the mean. People who get in studies are usually people who are not doing well. right? And as you all probably know with epilepsy, there are good times and bad times in the epilepsy world. And sometimes you're in the bad part, you get in the study, and you just happen to get into the good part. It had nothing to do with what we did as the treatment. Another reason why we have to have 2 arms and we have to have a lot of patients to get rid of just the natural fluctuation of epilepsy. So the responder rate, or that amount of people who had greater than 50% reduction, 43% of people in the CBD group and 27% of people in the placebo group. Now, I'll point out that is not statistically significant. It is statistically significant in their other studies, however. 3 people were seizure-free. In this particular study, none in the placebo group. I point that out, too, just because everybody on the internet appears to be seizure-free. They weren't seizure-free. Doesn't mean everybody on the internet is lying to you. It means the people on the internet may legitimately be seizure-free, but there may be millions of other people who have used it that aren't, and they haven't put their stuff out there. Adverse events, as I said, no drug is without adverse events. So 93% of people in CBD reported adverse events versus 75% in the placebo group. Almost all of the adverse effects were relatively mild. 8 people withdrew from CBD, 1 person withdrew in the placebo group. Serious adverse events were status epilepticus and elevated liver transaminases, so your liver enzymes went up. We'll talk about that a little more because that is an important adverse effect of this drug. Diarrhea is more common when taking Epidiolex, so that is another thing we see. Somnolence or sleepiness is also more common on Epidiolex, but it occurs almost exclusively in people who are on clobazam or Onvi. And we'll talk about why that is in just a little bit. So then the next study was in Lennox-Gastaut syndrome. This one includes adults. So now we're at ages 2 to 55. In this case, they had to have greater than 2 drop seizures. So in the first one, we talked about convulsive seizures, all right? Convulsive seizures are generalized tonic-clonic seizures, clonic seizures. We don't count myoclonic seizures, so quick muscle jerks, don't count that. We don't count absence because they're incredibly difficult to count and to use and study. So here we're using drop seizures. Drop seizures are atonic seizures, but also tonic seizures, also tonic-clonic seizures. It's basically any seizure that could result in drop. So my point is that these studies basically have some overlap of seizure types, and when all is said and done, we basically covered every seizure type except absence and myoclonic. So again, very similar design, 20 milligrams versus placebo, daily diary over 14 weeks. Here we saw, again, a 44% reduction versus 21% in placebo. Tell you, you're going to see a trend. Every study has almost the exact same outcome. So just another example of, I tell people, these drugs, and when we do these drug studies, rarely are these drugs developed for the condition, right? They didn't just make cannabidiol for Dravet syndrome. There's nothing magical about it for Dravet syndrome. They just chose Dravet syndrome as a group to study because they have a lot of seizures. And so what you'll see is even though we're talking about different epilepsies, you got very similar reductions in seizures because these are not designed specifically to the actual etiology. Adverse effects, again, more common in CBD, and 14% of the people withdrew from CBD while only 1% the placebo. Now, this next study is a little bit different. So this is also in Lennox-Gastaut, but here we're doing dose ranging. So in this study, we looked at 20 milligrams per kilogram versus a 10 milligram per kilogram dose versus a placebo. Otherwise, the design of the trial was very much the same. A huge trial, 225 patients in this particular one. And so what you can see, and this is looking at, if you just look across, it's drop seizures, total seizures, and then the non-drop seizures. And the treatment, which is the red or blue line, is statistically better than placebo each time. So CBD is better every time. What's interesting is that the 10 milligram group is not that much different from the 20 milligram group. And so that's an important thing to notice as well. There may be some difference, okay? So if you look at like 75% reduction and you look at seizure freedom in this trial, there were slightly more people who were seizure-free and more people who had 75% reduction in the higher dose group than the lower dose group. But if you take the whole group, basically they're quite similar. And so that's why when you look at the indication and the dosing for Epidiolex, the recommendations are to go to 10 milligram per kilogram per day. You can go up to 20 milligram per kilogram per day if otherwise tolerated, and you might get a little better efficacy. But for most people, the lower dose may work, which is interesting and brings you back to the original drugs you can buy online, Charlotte's Web, that actually use a lower dose. Maybe a lower dose potentially could be effective for some people. And I have seen that. I always start at obviously lower than 10 and work our way up. So if they get better at a lower dose, we just leave it there. Adverse events, still common, still the same kind, okay? So much more common in this case in a higher dose. So the higher you go, the more likely you are to develop the adverse effects. Again, diarrhea being probably the most common thing I run into. Sleepiness, you've got to be aware of. If the kid's starting on Epidiolex is on Onfi, very good chance that sleepiness could occur, so you have to be aware about that. When I initially started using it after the trials were over, I was trying to reduce the Onfi right at the outset, so if I started Epidiolex, I went ahead and brought Onfi down. I don't really think that was my best plan because people certainly got worse from the Onfi coming down. So now I personally just wait and see if they get sleepy before I take it down, as long as the family's aware to keep an eye out for it. So tuberous sclerosis, we have a little bit of data from that just from the initial press releases from the results of this. Again, a very large study, 225 patients. Again, we're dealing with both children and adults. In this study, they pushed it even further. So it was placebo versus 25 per kilo versus 50 per kilo. And again, same thing, primary reduction of seizures, and the seizure types in this one basically, again, almost contained everything. 49% reduction versus 47% reduction, so basically not different between the 25 and the 50 milligram group, but both better than placebo. Adverse effects were otherwise the same. More people in the 50 group, so 25% of the people on 50 milligrams had elevation of their liver enzymes versus 12% in the other group. And again, that's important. Long-term outcomes. So it's great, but these are all 14-week studies. So how does Epidiolex do long-term? Because 14 weeks is not going to be long enough to treat anybody, right? So this is the open label extension. So once these trials are done, once the blinded portion is done, people are given the opportunity to go into open label where they get on the drug and can continue on the drug until it's been FDA approved and they can get it. And so that can go on for years depending on how long it takes the FDA. So this data cut contained 366 patients from the Lennox-Gastaut group who were followed up an average of 61 weeks. Most were on just a little over 20 per kilo. And what they saw is that their seizure reduction at 12 weeks was very similar through the last point they looked at, which was a 72-week period. So that's good. That means, their benefit appears to be long-lasting. I will tell you, in open-label trials, the rules change. So in a blinded trial, nothing can change. I don't change any medications that the patient is on during that time because we only want to see what Epidiolex is doing. Once we reach open label, it's discouraged to change other things, but if I need to change other medicines, I can. So the fact that it's sustained is good. The fact that these people are still on it is a good indicator that it must be thought to be doing something, but some of the reduction in seizures could potentially be from other medicines being changed as well. Adverse effects, very similar. Now let's go beyond. We'll look at the compassionate use data. Compassionate use data was a program that Epidiolex, or Greenwich started with Epidiolex before they started their trials, giving people an opportunity to get it through individual sites. So there are 25 sites in the U.S. that had patients that were basically on a study, but this is an open label. They're definitely getting Epidiolex, and they could dose it anywhere between 2 and 50 milligram per kilogram per day. And it had 607 patients enrolled, and as you see on that list, beyond the top 3, which were what they did blinded trials on, this one now contains CDKL5, Dosa syndrome, duplication 15q, Aicardi syndrome, and some other refractory epilepsies. So this is evidence to suggest that it might be useful for something other than the 3 conditions they've already studied. And when I, just for your doctor's sake, if you are thinking about getting on CBD or Epidiolex for your doctor's sake, when you turn it into an insurance agency, almost always they are denying it unless you have one of those conditions, Dravet or Lennox-Gastaut. However, a case can be made with studies like this that it probably can be used for other things. And I have gotten it approved for other things as a result. But that's not what the label reads, so just know that. In this particular open label compassionate use, 24% of people withdrew, 89 of them cited lack of efficacy. Again, I told you the median dose. And convulsive seizures were reduced by 51%, 48% in other seizures. So again, about a 50% reduction in seizures. If you look at the 100%, which is the seizure-free, you had 11% of people saying they were seizure-free at 12 weeks and a similar number at 96 weeks. I don't know if those are the exact same people at those 2 time points. They could be different people. This particular study then looks at those individual diagnoses other than the ones there's an indication for. And again, as you can see, the reduction for some conditions, the iCardi group reported a 70% reduction in their seizures. CDKL5 slightly less. Actually, the other ones all are about the same. iCardi just reported slightly better reduction in seizures. So some indication that it could be used for other things than what the blinded trials were done. So as I said, it's metabolized by several liver enzymes, and this is important because these are enzymes that metabolize other drugs, especially other drugs that we use for epilepsy. So clobazam is an important one. So clobazam gets broken down in your body to something called N-desmethylclobazam. And N-desmethylclobazam is also active, just like clobazam is. So what happens is N-desmethylclobazam levels can increase 500% when you're on Epidiolex. And so you start the drug and things are going well, but as time goes by, the desmethylclobazam level continues to go up and you get incredibly sleepy. And I mean really sleepy. I've seen some very sedated children as it's gone up. So it's something you have to be aware of and keep your eye out for. The other thing is if you start it, I just encourage neurologists to make sure they're not just getting clobazam levels, because clobazam levels might not change. And so they'll look at it and they go, well, that's not the cause of your sleepiness. Well, they're not looking at the right thing. You got to look at desmethylclobazam. And both of those, you can get both of those levels. Co-administration with valproate, Depakote, is associated with an increased risk of liver enzyme elevation. So liver enzyme elevation occurred in people who were on Epidiolex without valproate, but also occurred more commonly on people who were on Epidiolex with valproate. That's like 75% of the time when a liver enzyme elevation was present, you were on the two drugs. So it's something to be aware of, which is why they recommend generally getting some baseline LFTs, liver function tests, and then repeating those levels intermittently after the dosing has been started. Other studies, the one I cited here, have shown that topiramate and zonisamide levels also increase with Epidiolex, but the increase is very minimal and probably not honestly that important. And there are elevations of rufinamide and Aptium have been noted, but also not fairly significant increases. So really that's just the valproate and clobazam are probably the two most important drugs to be aware of. So I just want to look at some conditions other than epilepsy and the potential. So a lot of people talk about it for behavior, and there are some studies of its use in behavior, but you have to know that these studies are not they're not CBD. These studies are studying something called nabiximols, which are basically combinations of 1-to-1 THC and CBD. And so, when you think about behavior and you see people say, hey, yeah, it's better, well, if it's got a lot of THC, it's a decent chance it might be better. I mean, one of the things THC does is can kind of mellow you out, so that might be very useful for behavior. But again, for the reasons I cited at the beginning, might not be our best option. There are some small studies in the adult population. Some of them do use placebo, looking at Huntington's disease and dementia, ADHD. In those studies, there has not been any significant improvement in cognition, agitation, or anxiety. But I still think that's probably an area of interest, and there's more to see with that. I mean, there's an awful lot of stuff out there about its potential for anxiety, for sure. So I think, there's still more to be done to that before we write it off completely. And there's others that suggest that hyperactivity and impulsivity may improve some of this too. So still worth looking into more. There is some work in spasticity. Sativex, which is again one of these 1-to-1 THC, CBD kind of compounds, is approved in Europe for the treatment of spasticity, not in the United States. There's some small studies in dystonia, very small, 2 to 5, where they've shown some improvement in symptoms. But again, we're talking about different compounds. We're not talking about CBD individually. Sleep. Several studies which suggest that CBD at low doses might actually make you more alert, and if it gets to higher doses may make you sleepy. Most of the studies that have looked at CBD as a treatment for sleep are looking at sleep in the context of people who have anxiety and pain, two other conditions it might treat. So whether it actually made the sleep better or it made their pain and anxiety better, and that's why they slept, is not clear. So just a little bit on what we'll say is artisanal or anything that's not Epidiolex and Epidiolex. So as I said before, the FDA regulates safety and efficacy, strength and purity, and the manufacturing of medicines. And that's what these trials are about. These other CBD oils are not subject to those requirements. And when you look at, there's been multiple studies where they'll go buy collections of oils and products and try to and analyze them and see what are they, just to get an idea. And almost all of them kind of often end up around the same way. And so this first one is actually looking at THC products, probably in Colorado or California, I'm assuming. So what they saw is that 59% of the products had CBD in them, yet their label only indicated CBD was in the product in 18% of the cases. They also found, as far as the THC goes, that about 17% of the time the amount in there was accurate, 23% of the time the label was under what was actually in it, and 60% of the time the label said that there was a lot more in it than was in it. I put down there at the bottom some other things. I talked about how the growing environment of the plant actually is quite important and can result in wide changes in what the plant contains. But plants are also bioaccumulators, so these plants are used to clean soil in some areas. So they pick up things like heavy metals out of the soil. That's what they're for. And so if these things are produced without a process which removes heavy metals, some of these things could contain heavy metals. Those aren't good for you. This is a study that just looked at cannabidiol, or CBD extracts that were sold online. And again, what I'll just point out is that if you look at the accuracy, out of the 84 that were on there, you had about 31% that were accurate, 42% were under-labeled, and the others were over-labeled. So just buyer beware, that's all. So what can we take away from what we've talked about so far? CBD in its purified form and as Epidiolex is effective for the reduction of seizures in Lennox-Gastaut syndrome and Dravet syndrome. And I would suggest it's likely effective for the treatment of other treatment-resistant epilepsies. The 10 milligram per kilogram dosing has a very similar efficacy to 20, with the exception being that higher dosing is more commonly associated with adverse effects, specifically diarrhea, somnolence, fever, vomiting, the most common. Be aware that liver enzyme elevations occur. While they are infrequent, they are more common in people that are on valproate, and the elevation of clobazam and its active metabolite will increase sleepiness. CBD, I suspect, will be found to be beneficial for other conditions, but at this point it's too early to really advise anyone on that and to suggest they take things for these conditions, because we simply just don't have enough information. Not all CBD oils are created equal, so I encourage my patients to utilize great caution. I don't tell them not to do it, as long as we're talking about it and I know they're doing it. I think it's important for us all to be aware of what's going on, so that if something does happen, we can try to make a decision of why that might be. So just beware. And there's much more study needed for all the other cannabinoids in the plant to see if there may be things in there that are even more useful than CBD. And that's it. feels like Texas in here. God. Here, do you want to use the mic? You pass it around.
So I had a question when you said you suspect that it could be beneficial for other conditions and that you got it approved for something else. When you said approval, did you mean in order for you to prescribe it or like insurance coverage?
So I'm talking about approval for the treatment of other epilepsies besides the two it's approved for. So for instance, I've got some kids with tuberous sclerosis that are on it now. It's not indicated for that right now, so the insurance company initially will deny that. But, I call them, I talk to them, I say, here's some evidence that it's useful for this plus this. I've also got a few other kids who, for example, aren't good surgery candidates. They've used lots of drugs of multiple mechanisms. They're not working. Call the insurance agency. I was like, come on. I mean, it's worth a shot, and they approve it.
Sure. Okay, so
Which is what happens with all drugs, right? When they first come out, insurance company is exactly what the indication says, denies everything else. And then 6 months, a year passes by, and it starts to loosen up.
I thought the indication was for seizures associated with Dravet and LGS.
It probably is read like that, yeah. Yeah,
Kind of like the Onfi.
yeah, it's like Onfi.
Yeah.
It's a very, which is one of the things right with Onfi is people start making the argument, well, my patient has those seizures, right?
All seizures.
And some insurance companies say, oh, yeah, and some go, no.
Yeah.
Nice
Are
try.
you finding insurance covering for other intractable epilepsies that are not TS, Dravet, or LGS?
I'm sorry,
outside?
what was that?
Are you finding health insurance companies funding it?
Some,
that
I
are
mean,
not TS?
yeah, but it's still getting, like I said,
it's getting on the
it'll get
TS.
denied right away. No, I don't think any of them have gone through the first time. And some of them I've had the conversation and it's still been denied, and some of them it'll pass. All depends on who's on the other end of the phone. All depends on how you approach them too. I tend to be very nice to reviewers. If you're nice to them, they're generally nice to you. But if you call them with an attitude, generally they deny you.
You gotta do a peer-to-peer on that.
Yeah, all the time.
Of those kids that you were able to get it approved for, that
Mm-hmm.
didn't meet the qualifications, how is it working out for them now?
I mean, I don't think it's any better, but it's no worse. I mean, I think this is about how it is. I think if you look at it, I suspect if it was used in people who had newly diagnosed epilepsy, the numbers would be higher. But that's the nature of newly diagnosed epilepsy, because 60% of people are seizure-free. So that doesn't mean that it's any superior. It's just that's that population. Because I get a lot of people that come in and they want it first drug right out of the gate. I want to be on Epidiolex, and I can't fight that fight for a newly diagnosed epilepsy when there's a bunch of other drugs that are indicated that we can use.
You're saying that the kids that are intractable epilepsy that you have prescribed it for
Yep.
are pretty much doing the same?
I think they're about the same. Yeah. I don't think anyone's, I don't think there's a group of people that are probably going to do something much better. Yeah.
Do you have any idea what effect it would have on ES epilepsy?
So, no, because it hasn't been studied per se in that. There's some small papers on, some really intractable epilepsy. There's a small paper on its use in febrile infection-related epilepsy, which is very bad when that starts, where they showed some improvement. But that paper also showed improvement, if I don't recall exactly how long, but these kids usually seize for like months when it starts. And at the time that they started using Epidiolex, obviously they were looking for anything, and the kid got better, and they might have gotten better, but it might have been that it was 6 months later, and it was time for it to stop. It's kind of hard to tell. So, I mean, I don't think it's, it's not an unreasonable thing to look at. You'd have to look at EEG. That's another thing. It's not usually part of drug studies. It's not to look at the EEG and see if the EEG actually changes, and that's what you have to do if you're looking at ESUS.
I'll just talk loud.
It's already on.
Okay, I was curious, is the federal government allowing for the research of other diseases and illnesses other than Dravet's and the other one?
Yeah, I mean, the federal government would always have allowed research of Schedule I drugs if you have a good protocol in place. It's always been difficult with marijuana because there have been in the past only a couple places in the United States that legally could grow it for research. One of them was at the University of Mississippi, where they basically weren't growing anything because nobody wanted it. So, anytime if you develop the protocol, and it's a well-derived protocol, you can study these drugs. And so there's definitely opportunity to study it for other conditions. I mean, Epidiolex could be studied for lots of things. They could put in for whatever they want because now they have a substance that's very clearly defined what it is. We know what we're studying. You have to go somewhat through the same processes for the other CBD oils, which is what people have, that's somewhat some of the things that we've said to some of the other oil producers. You got on your website that it works. Well, do the study and show it works. That's all we ask.
I guess I thought it was illegal still for researchers to work with marijuana per se.
No, you can do the stuff, right? So when we did the trials, we had to have Schedule I license. So I had to have a Schedule I license to study, and we had to study it under strict conditions, right? So when the patient would come and it would come from the dispensary. It had to be escorted by a security officer from the investigational pharmacy down to clinic, and then I would hand it to the patient and they would walk off. And I don't know, whatever. Those are the rules. Yeah.
Do you know the status of the CBD oil as it's being studied for other forms of epilepsy right now, other than the two that we talked about here today?
So how do you mean? You mean as Epidiolex?
Right, Epidiolex, are there studies that are ongoing right now trying to look at its effectiveness with other forms of epilepsy?
So they just finished the tuberous sclerosis one, so we don't have the data on that. That's the last one. They have a open label one. I think they're looking at maybe for LGS, just more long-term LGS data, the same one.
For focal epilepsy that you're aware of?
No, but in reality, honestly, it's not necessary, really, right? Because again, with all drugs, you do what you got to do. You got the FDA approval. The drug's in the pharmacy now. It's going to get denied for a little bit, and then it's going to open up. I mean, almost every drug you guys use, Onfi, Banzel, they're all approved for use of seizures in Lennox-Gastaut syndrome, and then they end up being used for all kinds of other things like focal epilepsies, et cetera.
Well, sure, I was going to add this because what we're running into, my wife and I, it seems like our neurology team is saying, well, this isn't even, qualified to address, what your son's type of seizures are.
Right.
Which
What I
is
think
opposite of what you're saying.
what I think is what they probably really mean is it's not indicated for focal epilepsy, and so they know if they turn in that prescription, it's going to get denied, and insurance won't pay for it. Doesn't mean they can't do it. They can. I've put kids with focal epilepsy on it. Again, these are kids that I think I've got a good case. They've been on multiple drugs of multiple mechanisms of action. When I talk to the insurance company, I say, listen, I've put this kid on this. We've done diet. He's not a surgery candidate. What do you want me to do? I mean, come on. It's worth a shot. If it doesn't work, it doesn't work. So, it can be approved. But if you're a patient that's probably only been on a couple things, they will deny it over and over and over again. Yep.
Thank you, sir.
You bet.
Have you done any use with it for hysterectomy patients who had seizure return?
No, I can't think of any of the ones at least in my site. And I don't have any patients outside the studies that had it, and I don't think there were any in my site that had that. But again, I don't have any reason to think it would be any different.
Sure.
I really don't. These drugs just, in general, are not designed to treat the etiology. They're designed to treat the symptom, which is epilepsy, right? We are getting into a time of medicine now that we are defining genetic reasons for many of them that we're actually going to get at treatments, I hope, that are actually go to the etiology.
I have another question.
Mm-hmm.
So what would you say if somebody came to you and their child was on 2 different medications and they wanted to try Charlotte's Web in addition to the medications that they're already on?
So it depends, because I get that question all the time. And it depends on a lot of things. So it depends on the seizures, right? So let's just use an example. I get a lot of kids who come in.
Focal epilepsy.
Okay, so you come in with focal epilepsy.
Getting close to home here.
Okay, no problem. So you come in with focal epilepsy, and I'll say, one, there's some limited evidence because patients in some of these studies had focal seizures, like the TS study, right? So we know about what it does. It's about a 40-some-odd% reduction. Not bad. These are the side effects. All right, well, here are other drugs, and here are the potentials. Here are their studies results, and let's weigh them out. I mean, that's how we have the conversation, and with the caveat that some of these I know exactly what you're getting. If you do Charlotte's Web, I'm not sure what you're getting.
Right.
I mean, I have not denied parents that. Once we've talked about the risk and benefit, I say, hey, you want to give it a shot? I mean, there's been many that I've got a couple that I said, listen, can we just get this over with and let's just do this, please, so we can move on, and we've moved on, and then some of them it's worked, so.
Because I'm just thinking a lot of the side effects in the medications.
Sure.
That maybe the CBD would help balance that out, or maybe bring some support to the areas that those medications are really
Potentially.
Yeah.
Or it may cause some. I mean, it's no different from other medicines in that way. You don't know. I mean, you got a basic idea of the problems you may have. Your kid may not have none of them. Your kid have all of them.
Yeah.
So it's not an unreasonable thing to do. And then we also have to look at the price.
Yeah.
And that's something we always have to always talk about with families. I was like, listen, this is how much, let's talk about what it costs and what you can afford, this is the dose. So just know that if that doesn't work, and we're going to try to titrate it up to a dose, for instance, that we'd use for Epidiolex, again, understanding they're not the same, but we're still talking about CBD to some degree, you might not be able to afford it. It gets ridiculous. Sorry.
Yeah, obviously there's been a tremendous social request for research in this area. And, it's interesting, and you may have touched on this earlier. I'm curious, as someone who works in this field, do you think that we're putting too much attention in this area when perhaps a group of advocates like us should be aware of other areas with as much promise?
Sure.
That we may want to start raising
Yeah.
awareness on as well.
I mean, I think we put an awful lot of energy into this. That's for sure.
Yeah.
There's been, and look what it's done. All right, so that's great, And I think, I don't think it's necessarily wasted energy, but I think we've got some information. So if we're not going to focus on beyond CBD and other things, then I'm not really sure if it's necessary to continue to be on this that much. I think it's actually quite important to focus on your specific etiology and raising interest and awareness in that. I mean, I think, I talk about Dravet all the time because I deal with so many Dravet patients, but they have been so successful in, as a family support group, and getting people interested in their disease. I mean, there are 2 drugs approved in the last, or 3 drugs approved in the 2 drugs with 1 about to be approved in this year. You've got another trial ongoing with their syndrome. I mean, this is something that's 1 in 25,000 people, and you got 4 different drugs that have got interest in them, and you've got companies developing genetic treatments to actually cure their disease. So you have to get, I think it's almost better to focus on our etiology than on these particular drugs sometimes, especially where we are now. I mean, it's there. So unless we're going to turn our focus to something else in the plant, which I think is reasonable, let's continue to work through the plant. But
You want me to do one more question?
So do you have any other questions?
And I'm sorry if this didn't get asked, I had to go get my daughter.
No worries.
What I'm most curious about is if we look more into CBD, right now, we have no physicians that do CBD, and she's on 1 seizure medication, because even after surgery, she still has seizures, and it's controlled, although she keeps outgrowing the dose. Can you combine CBD with a current seizure medication?
yeah, so I think you stepped out when we talked about at least the 2 medicines that are important. So Onfi and CBD don't go, they go well. You can do it, but you can get sleepier. You just have to be aware of it. And valproate and CBD can increase the risk of elevation of liver enzymes. Those are the 2 most important. Most other drugs will probably be okay.
She's zonisamide.
Yeah, so zonisamide has been shown to have a slightly increased level in the setting of CBD, but not really enough to probably be.
Do you recommend,
Worry.
like, a parent going out and getting their own? I'm not going to hold you liable. So I know you
Oh, sure. It's on video.
I didn't mean to say it like that. But do parents go out?
Oh, absolutely, they do. I recommend having a really good conversation with your doc. I recommend being very open with your doctor about what you're doing. I tell you that you have to be careful. I run into a lot of doctors who think they know something about CBD and really honestly don't know all that much. So you just want to make sure that you have a good conversation and everybody's fairly informed about what you're doing.
Thank you so much.
Thanks.